Okay, so good afternoon. I think we're just about afternoon. Everybody, my watch still says it's 5 to 6 in the morning, but I've moved on since. Myself and Aisling are absolutely delighted to be here and delighted to do this presentation in a collaborative way. I was equally as pleased, though, to come in and know so many faces. So certainly when I began this, one or two faces here in the front row even is actually putting names to faces, people like Saoirse back there, that maybe we've had contact or collect different people that we've actually had contact and we hadn't had the opportunity to meet. So there is something, Molly, about just a growing ripple effect and a growing network that is really starting to do what all of this is about. So just a little bit of what we're going to cover. It's a short presentation, but we're going to give you a little bit of background on the Nurture programme. Going to outline some of our key deliverables. The approaches, and more importantly, I suppose, the approaches that are going to be used to create and use knowledge for evidence-informed policy and practice, and then the inevitable challenges, because we're very much working in a system setting, we're very time limited, so there is quite a pressure to get our deliverables into the system and do it as well as we possibly can. So in terms of the background to the programme, I suppose it really has come about and is made possible by a grant from Atlantic Philanthropies. Now, many of you might be aware of some of the work of the Atlantic Philanthropies in Ireland. They've had huge investment in academia, in older persons, dementia, and in child health. They've invested in excess of 120 million in Ireland, primarily and mostly in areas of targeted intervention, targeted need. But certainly as a legacy, and as they cease their operations in Ireland, the opportunity arose and they supported, through this grant, the opportunity to invest and build really on their learning in universal child health services. So it's made possible, and it's actually the final point, but a very important one, that it's implemented within the health services. The grant is managed through the Catherine Howard Foundation, and we've the very important support and collaboration with the Centre for Effective Services. And that focus on implementation science has been incredibly important in our work, and really we feel has made an enormous difference. Sometimes it may have, and this is a good thing, it may have meant we had to pause and we had to pace ourselves a little bit more to maybe think about the multiple perspectives in terms of the outputs. So in essence, the programme is a quality improvement programme for universal child health services, geared towards and focused on not additional staffing, but improving the information and the professional supports that are provided to parents, really from pregnancy through to the first 3 years of the baby's life. Now it's referred to as the 0 to 2s, but in essence it's pregnancy through to the child's 3rd birthday. And I suppose one of the real benefits is that it's being implemented within a very strong service setting. So this is the service that I suppose I would consider to be very much the unsung hero. And it is, as you spoke earlier this morning, it is that public health nurse. Primarily, it involves obviously practice nurses, GPs, community medical doctors, midwives, but fundamentally, the bulk of the visits that are made to that new mum and baby are actually made by the public health nurse. And it's an incredibly important resource and support, and they have an incredibly important opportunity to influence the future health of these babies. We're building, and it's fortunate that we're building on a very significant evidence base on the importance of prevention and early intervention, and you'll see that through a lot of the policies. So Healthy Ireland, Better Outcomes, Brighter Futures, the new early years strategy that we're hoping will be launched through DCYA in September. So it is a very positive policy environment, but not without its challenges, as you'll understand. Our vision, it's very aspirational. I think if we were in a randomised control trial to try and say who takes credit for improving child health outcomes, but it's an ultimate vision. We know we're trying to deal with multiple subject areas, and no one trumps the other. So it's not about breastfeeding alone, or about screen time, or about physical activity, or language development. It's not about any single one of those things. But parenting and child health is complex and it's multidimensional and involves, I suppose, a multitude of subject areas, all with a growing and new evidence base, but also this really good new evidence that we're continuing to try to access in terms of what really impacts, what is behaviour change, what will actually make an individual, or in this case a parent, want to do things differently with a child. So how do you communicate that? We're trying to achieve system-wide implementation. So we want this to happen in the visit with the midwife, or in the public health visit or the immunisation visit with the practice nurse, whether it is in the heart of Dublin City, Cork, Galway or out to Inishmore, wherever it is, that's what we're trying to, and that brings about extraordinary challenges. We want to try and secure consistency in message, and some of the methodologies that Aisling will speak about, where we've actually asked parents, they said they hugely trusted the system, but that we weren't necessarily always giving them the same message, and even within practitioners' groupings. And they also said that actually is quite stressful. So you then find yourself on blogs and trying to figure out, well, should I be weaning at this stage, and am I doing the right thing? So really it's an enormous challenge to try and hone in on the, distill the evidence, hone in on the right message and make that available and be consistent through the various platforms. We're also needing to recognise, and I think this is now well established, when the programme began, there probably was still more of a reluctance to accept that actually social media and an online presence was where we had to be. And that was another very strong message from the parents to say, look, we think you're okay, but in actual fact, you don't have a great, and you certainly don't have a responsive presence in an Irish, in terms of the HSE. So recognising this and actually using the evidence about how parents respond to how they source information. So we were able to, when you start to look, we're able to get wonderful information through digital analytics, etc., around, how parents, the kind of questions they ask, the length of time they spend on existing pages, the type of feedback. So we're able to build on a lot of this, which is really good. Then really importantly, trying to align with other public health programmes and campaigns. So Maria O'Brien here in the front row, so making every contact count. We've had multitude of teleconferences and calls and sense checking, and they will participate in the expert review of some of our modules. Likewise, Marion I got to meet in terms of the alcohol programme, QUIT, healthy eating, active living. Sarah, we've lots of contact. But I think it's also really, really good that we have a collaboration and we're working with the infant feeding intervention with the church programme in the context of, again, a particular area that we'll look at an intervention with practice nurses. And that to us is absolutely really connecting and starting to see a map that's coming together very well. This is our service context. So as I've said, it is that primary core visit that really is a very well kept secret until you're actually part of the service and perhaps using it. So from the first booking visit, there are a minimum, everything going well, there's a minimum of 25 contacts between that first booking visit through to your child's 3rd birthday. So that, we've an average birth rate, I think this year it's down to about 62,000. You look at that many contacts across this year's birth rate and the existing 1-year-old, 2-year-old, 3-year-old, it's about 6 million opportunities. Now we're certainly, as you said earlier, we're not hoping that we can make every contact really count, but we're certainly hoping to really do our very best in terms of how we access this wonderful system that really exists and is so, I suppose, so potentially accessible for us if we can mobilise it. So the outputs of the programme, we think really in terms of 4 key strands, and these are just some examples. So we think about our public information. So the first 3, recognising this need to have a better online presence. So a new child health website for parents. It's a beta test site at the moment, so it's not there yet. But within the next month or 2, there will be well-developed, and user testing is happening at the moment, for probably, our comms person was saying that probably about 480 discrete subjects on that. Very much framed. It won't have lots of fancy stock images, but very much based on the fact that the parent tends to Google the question and that it gives the straight answer and tells you where you want to go for more information. We've also recognised we weren't starting with this information in a consistent way early enough. So there's a healthy pregnancy book that again is, so all the maternity units provide wonderful information. Some are books, some are folders of leaflets, and this brings this together and has been quite a mammoth task in bringing together all of the evidence from some of the programmes I've mentioned, lots of other sources of information, but also then seeking parents' feedback on those materials, and they've been really well received so far. Updates of existing resources like the Caring for Your Baby books, again, well received within the system, but certainly needing new evidence and new approaches. When it comes to then a second pillar of this, so that's the public information, staff, training and resources. There's a major programme of work underway in terms of developing training and a framework to support that. But actually one of the things I didn't mention here is that I refer to us needing to have what I would call a resource hub. And that is for the practitioner who might be up in Buncrana in Donegal to have as a reasonable shot at accessing new information and evidence, just as perhaps the person who's in the University College Hospital, to actually have, again, what I would call, I suppose, the distilled evidence. We're looking at standards for antenatal education, but our research that Aisling will talk about has brought us further to say we actually need an initial indicative core curriculum. So the high-level standards in a HICWA format just aren't enough. There's quite a focus on in terms of other resources. So infant mental health, fundamentally recognising the importance of the baby's capacity from birth, and I suppose the importance of that parent-child relationship. There's a big body of work, and there's an implementation team focusing on that alone. We can't ignore the system, and right now, that second last point, if you moved your child from Ennis to Galway and then you subsequently went to Nina or Burr or anywhere else, you would have a different record in each of those areas. And really over the last 10 to 15 years, the model that existed and was there initially under Best Health for Children evolved. There was no national structure to coordinate this. So if you want, while fundamentally it is a management tool in terms of that parent and child, if you want to actually have the data and you're looking at child health outcomes, you need to start with consistency of what's actually being collected. And then finally, some standardisation of screening tools. Probably the most tangible one in the middle of rollout at the moment is at the 21 to 24 month visit is the rollout of the ages and stages developmental assessment, so that there is a consistency in the assessment and the flags that indicate referral onwards. So from that, I'm going to hand over to Aisling.
Great, thank you, Anne. So I'm just going to say a few words just about some of the approaches that we're using to create and to use knowledge and to support implementation of the project. So firstly, as Anne mentioned, there's a whole range of topics that need to be covered. So we're doing quite a lot of scoping and evidence reviews to look at these various topics and working collaboratively with others who work in this area. And also looking to see is there any evidence around implementation. So a number of the interventions that we're rolling out have been trialled in different parts of the country. So looking at the evaluations and the research that have been done and helping that to inform decisions around how we scale up and how we bring things to a national picture. Secondly, just to say a little bit about the consultation that we're doing. So really important for us is the generation of evidence from service users themselves and also from the practitioners working on the ground. And that's really, really important for us in terms of looking at the fit and the feasibility and the implementability of a lot of the interventions that we're delivering. And then thirdly, I just want to say a little bit about our implementation team structure. And we have 6 implementation teams, national teams, that oversee the implementation of the work. And really, I suppose they're key in terms of overseeing the creation and the use of knowledge and making decisions based on evidence to inform implementation. So very briefly, just going to say a little bit more about each of these things. So in terms of scoping and evidence reviews, we've done quite a lot of different evidence reviews on different topics. Most recently, Anne mentioned the review of national child health records. So there's lots of different records being used across the country. So a research team were contracted to look at the various records in use across the country, to scope that, to look at commonalities, but also to look at the national and international evidence base on what is helpful and useful to have in a national child health record. So that's just one example of the evidence reviews that we're doing. We also have introduced quite a number of quality assurance processes. So for each of the subjects that we're writing content and writing and developing resources on, so for example, infant mental health, we have a subject matter expert, generally based within the HSE, who develop the content, but we also have then review processes in place to quality assure the content, but also to make sure that it's accessible and usable with our users, so parents and practitioners. So there's quite a lot of work around testing material and testing resources with the users themselves. Also, just to mention, for the website, the mychild.ie website, the team in HSE Communications are using best practice in terms of digital development. So following work that has been done by gov.uk in the UK, and this methodology that is based on best practice principles has been used for the NHS Choices website as well. And it's really about organising and presenting information in a way that best meets user needs. So looking at the user, what are their needs, what are they looking for, how can we present information in a way that best meets user needs. Secondly, just to say a little bit more about the consultation work and the co-design work that we're doing. So we're really trying to co-create knowledge with a whole range of stakeholders, particularly practitioners within the system that we're working with, and also primarily parents, as they would be our primary service user group. So we've done quite a bit of consultation, generally with parents, really to inform the work, to ensure that we're meeting parent needs, but also to test outputs. So for example, the website, we have kind of a beta version that's live at the moment. Well, it's not quite yet live, but we do have a test site that is being currently tested with parents so that we can make improvements and further develop that further. We also have consultation and engagement with practitioners around a whole range of different topics. This is really around exploring implementation, exploring enablers, exploring barriers, but also things like acceptability of interventions. Is it possible to adopt? Is it appropriate for different contexts? So for example, with the Ages and Stages questionnaire that Anne mentioned, that developmental assessment that public health nurses will be using, it's been trialled in a few parts of the country, so we really wanted to consult with practitioners and understand some of the things that worked, some of the challenges that they encountered, to help inform how we would roll that out nationally. Also importantly, working with practitioners to help develop strategies for implementation, so building on things that have worked in other initiatives and in certain parts of the country, and seeing how can we mobilise those. Also, just to say around the consultation, we did a national survey. We had 4,135 parents open the survey, 2,787 parents completed it. And our implementation teams worked collaboratively with us to develop the questions for parents so that we could see what were parents' views on a whole range of the outputs that we're developing and use that feedback to inform the work. And that's a work in progress at the moment. The teams are currently reviewing what's come out of that parent consultation to inform the work. We've also done focus groups, and the HSE contracted COIN Research to do a number of focus groups, and also we in CES conducted some focus groups with more harder to reach parents, so parents in homelessness services, in direct provision services, etc. And there's been a whole range of ways in which this feedback has been used to inform the work. One small example is just the name of the website, mychild.ie, came from focus groups with parents. And also another example would be we asked parents to tell us what kind of information that they wanted and they needed for something like a parent website. And they came up with a whole range of topics that perhaps the HSE mightn't have traditionally talked about. So for example, baby-led weaning and topics such as that. So now that's a big focus on how do we plug some of those gaps in terms of the knowledge and information that the HSE has been providing. This is an example of a workshop that we conducted, and this was focused on antenatal education standards, where we brought over 100 antenatal educators together to look at draft standards, to test the kind of appropriateness, how accessible the language was, etc. Got their feedback to further develop them, but also importantly to look at what were the implementation issues and how do we develop and support this work. And Anne mentioned, coming out of that work, we've decided to develop a core curriculum for antenatal education. And then finally, just to say about our 6 teams. So this is our structure to oversee implementation, and they're really, really key in terms of driving the work, but also in terms of looking at the evidence that's being generated across these various different methods and making decisions on the basis of this. An example would be that antenatal to postnatal team, looking at those antenatal education standards. There's looking at evidence from the parent consultation work, the workshop that we did, but also surveys that we did with practitioners on the ground and managers on the ground. So quite a challenge in terms of bringing and integrating all of that evidence and using it to inform decision making. So it is challenging, but we feel there's great benefit in terms of getting all those voices and perspectives. And importantly, just to note that our implementation teams are made up of a broad range of disciplines and also geographic spread. So it's important for us that we have different parts of the country represented, given that the services look differently in different parts of the country, so to get that multiple perspective. Now just finally I'm going to hand over to Anne just to finish with some of the challenges and opportunities.
We have about 45 seconds.
Okay, I'll be very fast here. I suppose just out of the challenges, you know, some of the presentations actually even earlier today when you talked about the need to convince the funders, and we're at that place at the moment where there are multiple competing demands, so the evidence is critically important. Maybe to come down to the third one there, pace versus process. We are applying as rigorous a methodology as we possibly can, but we are extremely pressurised from a time perspective. So there's a certain level of, yes, we apply the method, but we have to get on with it and we have to get the material out there. And we hopefully will continue to refine those materials as we go along. The third point as well is incredibly important. We know that while developing every single training material or module or online unit is challenging at the time, we actually know that that is kind of the easy part, and that really it is the coaching and mentoring environment to ensure fidelity to practice that's where the real challenge is if we're to actually get this right. And we'll be watching the progress of MEC, who are just that step ahead of us around some of this, you know, because that really is how you make that work. We do know though that we're in the middle of a huge opportunity. I think, you said earlier, you think that you two have the best job. I think the job I've got is just fantastic, because never before have I been in a place where, you know, so I'm originally a speech and language therapist. I would have fought for the keys of the health centre to run a parent group in the evening because you knew that was the time they could get to it. Having the funding for this period of exploration, planning, resourcing, and having this collaboration, having the expertise in terms of implementation science with CS, etc., is an enormous opportunity. So we're really relishing the challenge on that. Also a point around, having that external oversight brings some challenges, but is an enormous opportunity. And we also know that some of the pressures they also bring to bear in terms of advocacy within political circles. And then finally, we know there's an enormous commitment to use of the data and the evidence, and the practitioners want that. And then also, just in terms of the programme, we have within each of our 9 community health organisations, we're currently just in the middle of recruiting a post that will be a child health programme development officer. For us, there is a sense of this. This will have life beyond the lifetime of the programme. So, apologies for the extra 2 minutes.
Thank you.